When futility rears its head in our nursing practice, it is our first duty to ourselves and our patients to take a pause, stop, and reflect with a learner mindset on what is it that I'm not seeing in this situation? Whose voice is not being heard? What are my assumptions and biases? And then think about what's another narrative that I can write about this situation.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. Today we're talking with Kathleen Turner, a clinical nurse in the Medical Surgical Intensive Care Unit at the University of California, San Francisco Medical Center, about futility of care and treatment. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thank you for joining me today, Kathleen.
Thank you.
I think this is such an important topic and one that oncology nurses definitely are going to encounter in their time on the job. And also just in light of the pandemic and everything that healthcare has gone through over the last few years, it's something that kind of has come to the forefront a little bit more even, and is an important topic to talk about. And our listeners that we have for the podcast, we have a lot of new to practice nurses out of school, a lot of nurses that are new to oncology. So these are going to be things that they're thinking about during their practice. So to start us off, can you briefly describe medical futility?
Medical futility has traditionally been framed as care that can't achieve its stated purpose. For instance, treating myocardial infarction with an antibiotic. There's no way that that medicine is going to fix somebody's heart attack. Often, though, I think it is something that we tend to invoke in our own practice when we feel like our care that we're providing may not be able to achieve our goal for the patient. And I mean our personal goal as opposed to a clinical goal. And from there, moral distress arises.
Thank you. Yeah, moral distress. I think that's something that nurses deal with so frequently. And it's so important to acknowledge that and to understand how we're going to deal with that. And I think understanding medical futility is going to help tremendously. So when you have a patient, who would be the person that determines when treatment or care has become futile?
That decision is officially within the realm of practice of the attending physician. To keep it from being quite so subjective, a lot of facilities, protocols, and organizational policies require the agreement of two attending physicians, one not involved in the patient's care, to say, we've reached the point of futility, that treatments that we're providing cannot achieve the results that we prescribed them for originally. I think that there's a tremendous opportunity for nurses to also actively participate in that conversation, especially oncology nurses, because we are with patients throughout their continuum of care and work with people for a long time and may have more in the room time with our patients. I think of, the nurses who have been giving my own mom her chemotherapy, where they spend so much time in the room with her and talking about her impressions of her care, what she wants, what's important, what's a meaningful result. And we can share that with our physician colleagues.
Excellent. You're so right. Do think about the times, that I spent with patients and just the vulnerability that they have with their nurses and talking through what they're experiencing and what they want their goals to be throughout this treatment process. So I do think that having the nurses involved and being able to be that advocate for the patient and letting the medical team know what they're thinking, what they've expressed to them is so important.
I think our patients, they don't have quite the need to impress us as they have with our physician or nurse practitioner colleagues. They can say things to us and, just as you point out, be vulnerable with us in a way that they may not feel as comfortable being with providers and even sometimes with their own families. We're sort of the hub with many spokes of information coming in and out. We have a great opportunity to get everybody on the same page.
Exactly. With this topic also comes an area that I think most medical professionals or the care team deal with at different points, in caring for patients, but that would be ethical or moral challenges. So what do those look like? And what types of challenges do nurses confront when it comes to futility of care?
Let me use an example because I work in the intensive care unit and medical intensive care unit. So one of our big patient populations is the oncology population. And I think about some of our patients who, have been through so many rounds of treatment, surgeries, radiation therapies, chemotherapies, immunologic agents, and have come into the ICU with some kind of complication, either of their treatment or of the cancer itself. They are hanging on by a thread to life, and their hope from their family in articulating what they last heard from that patient is that that person could get well enough to get more chemo. From my view as their ICU nurse, I'm not entirely sure that they'll make it to breakfast. And I worry that continuing to do all of these things for this person is going to actually shorten the amount of time that they have left and also make the quality of that precious time even worse, that I'm actually robbing hours and days from that patient and their family. And that's where it feels like the care that I'm providing comes right up against my oath, my vows as a nurse to do no harm and to provide benefit.
It's a good example and definitely things that I think all oncology nurses are going to experience at some point during their career.
I think it's the question of, because there is another thing that we can do, should we do it? That feeling of futility that clenches at our heart, at our guts. That's a signal to us to stop and think about, what is the goal of treatment? Whose goal is that? And is what's happening right now, is that aligned with that goal, or have we somehow gone astray?
Yep, exactly. So with those challenges, can you give some suggestions to nurses on steps that they can take to combat that?
When futility rears its head in our nursing practice, it is our first duty to ourselves and our patients to take a pause. And that's been a really helpful part of my nursing practice and something that became really important after reading an article by Cinda Rushton, who's a nurse ethicist from Johns Hopkins, who wrote an article called The Art of Pause. And it talks about our opportunities to just stop and reflect with a learner mindset on what is it that I'm not seeing in this situation? Whose voice is not being heard? What are my assumptions and biases? And then think about what's another narrative that I can write about this situation. Trying to be very mindful of other patients that we've cared for in similar situations where we might be bringing or projecting these other patients onto this current patient. We might find ourselves talking to our coworkers saying, oh, this is just like that other guy. This is like that lady that we had last year with blah, blah, blah. Just remembering that this is an individual person with their own goals, their own hopes and fears, and thinking, what can I bring to help achieve what's important to that patient? Can't be everything, but something. What's the most important thing in that person's bucket list? Is there some way that what's being proposed could serve that goal?
Thank you. Those are some really good suggestions. As we talk about this topic of futility, it doesn't only affect the patient. Who else should the nurse take into consideration when providing care?
That's a good question, Stephanie. And I think that's the open door where we can just walk right past futility and into something that gets us out of that bind of moral distress and moral injury. So looking at, there's the patient, their perspective, their needs and goals, their each individual family member, their needs and goals, then recognizing that that family system even has a history, people that get along, don't get along, who are the decision makers, what's their dynamic been over many years, and recognizing that the family members who are left behind when our patient dies, they still have to go on with the rest of their lives. They're also in a position of potential moral distress where they may not agree with our patient about what should be done. There are all of the people on the treatment team, ourselves as the nurses, our oncologist, NP and MD colleagues who've invested so much over often years and years, being partners with this patient, saying, if you stick with me, I'm going to stick with you and help you through this really scary disaster that's fallen into your life. And they've been through so many ups and downs already. They have also a tremendous emotional investment in their patients. And it's got to be so heartbreaking for them when someone that they've been taking care of for 5 years, 10 years, reaches the point where they really have very little time left. And there's really not much more that can be done to try to save their life. And I think, again, that's where it's really helpful for us to pause, take a breath, and put ourselves in the shoes of everybody else in this situation and think about what are they hoping for? What are they worried about? And from there, I think often there's some piece of common ground in all of these different perspectives. And we just have to stop and look until we can see what it is.
Kathleen, I think in the busyness too of, the workday and caring for patients and making sure that you know what all the new treatments are and the side effect management for them and just all of the things that the healthcare team has to take into consideration and, all the tasks that are being done. your comment of taking a pause and really being able to be reflective and look at who is around, what their feelings are. And I liked your point about walking in their shoes and just considering that. I think that's such an important piece, especially when you have a patient that is at this point. You've got their feelings, you've got the family's feelings, as you've mentioned, you've got other healthcare provider team members' feelings and thoughts on, have we done enough and did we do enough? And those are all hard things, in this career that we've chosen to do. To be able to step back and reflect and kind of reassess everything, I think is so valuable.
Stephanie, could I give your nurses a quick mnemonic to put in their pockets?
Absolutely.
In nursing school or when we're changing specialties, we have to learn a lot of new abbreviations and mnemonics so that we can call things up really quickly in the moment, because you're so right. We're so busy, especially now in pandemic times. Several years ago, when I was really going through some struggles in the ICU with this issue of futile or potentially inappropriate care, I went to a workshop and learned this mnemonic called GRACE, GRACE, to help clinicians remain compassionate and see what is the ethically appropriate thing to do in really fraught situations. And the letters stand for G, gather your attention. So bringing our attention right to this moment, not projecting into the future or remembering something that just happened in the last patient's room, but right here and now. And then R, for recall your intention. What are you really about? As a person, as a nurse, what are you hoping for? What are you bringing to this moment? A is attuned to self and then other. So as nurses, we're trained to jump right into assessing what's going on with that patient, what's going on with that family member sitting over in the corner, but instead assessing ourself first. So checking in with ourselves. Am I tired? Am I irritable? Do I have biases against something related to this patient and family? What's going on in myself? What are the filters that I'm seeing this patient and their situation through? And then once I've got a sense of sort of what baggage I'm bringing into the moment, I can attune to that patient and their family, or to a physician, even if I'm in, maybe in a family meeting, and sort of feel into what's going on with that person. Do they seem scared? Do they seem checked out? Do they seem angry? Do they seem mistrustful? What might they be hoping for? Kind of what we were talking about a minute ago, putting yourself in people's shoes. And then with that, all of that diagnostic information, go into C for consider what will serve. And really being curious about what are the possibilities here in this time. We can get really stuck on what's not possible. So sort of bracketing what's not possible. We're not discounting it, but just sort of setting it to the side temporarily. And then being really curious about what is there that we can do? What can we offer? And then E is to engage. So going ahead and doing it, see what happens, modifying our approach, PRN. And then really importantly, end. Going ahead and giving ourselves acknowledgement for our effort, whatever the outcome was, that we did our best with what we had, and letting it go. Let us be able to go home with whole heart and to savor whatever's waiting for us in our regular lives, and to be able to come in fresh on our next shift and to that next patient. So gather your attention, recall your intention, attune to self, then other, consider what will serve, engage, and end. And you can practice doing this with your own family, with wacky people on the bus, sort of less intense situations, and then pull it out of your pocket when you're at work. And it really goes very quickly and is something that you just can lean into in really difficult situations. And it only takes a moment.
Kathleen, thank you so much for that. That is perfect. What a great tool that we can put in our pocket and use in those situations.
It's been a way for me to really uncover possibilities that I could not see and bring some comfort, some peace in moments that just seemed 100% awful, and has helped me to keep going as a nurse, and has helped me to sort of shepherd patients and families through really, really hard situations.
Excellent. I think that's so important. One of the things that you mentioned was, when you're working with patients, and I think you mentioned it when you were talking about thinking or considering physicians and that, well, there might be one more treatment. But what are some ways that nurses can balance, when they're seeing all of the clinical indicators from a treatment and what that's telling them versus what that patient is telling them in those vulnerable moments that they have with the nurse, whether that's on the night shift or in the outpatient department, even, when their family member drops them off for their treatment and they're just sitting there by themselves and the nurse is sitting beside them while their treatment's going, and really having that kind of open conversation. Can you talk about that a little bit?
Yeah, I worked night shift, and definitely a lot of raw moments come up when families are not there and the things are quiet. If what a patient has said to me, I think about a patient that I had as a new grad nurse who, we had in the unit for, I don't know, it seems like months in memory. It probably was just a few weeks, but had been through so much and just was not going to get out of the unit, but had really been so strong and so patient. One night, he just looked at me and said, "I'm through." And I just kind of looked at him like I couldn't quite figure out where he was going with that. And he said, "I just can't do any more." I was like, "Any more of this?" And he just kind of nodded and was just, "I'm done." And I said, "That's different than how I heard you talking earlier with your wife. Is she aware that this is how you're feeling?" And kind of teared up a little bit. "No, I can't tell her that." I asked him, "Would it be okay with you if I talked to her about that? Would that be helpful?" And he said, "Yes." And I said, "Would it be okay if I talked with your doctor about that?" And he said, "Yes." "Well, let's do that. And we take it from there." And so when his wife came in the next day, I kind of steered her over to the coffee area of the unit where things were kind of quiet. And I said, "How are you with what's going on?" And she was so proud of him, everything he had been through and how hopeful he seemed. And she was tired. She'd been in the ICU every day. And just like a lot of our oncology families, they've been through so many ups and downs with the person that we've just known as our patient, but the person that they live with 24 hours a day. And I said, last night he shared something with me that I wanted to check in with you about. And I shared what he had said about just not being able to keep going with this plan. She was appropriately very sad, but grateful to know that this was where we really were. I went, as this patient's nurse to the doctor and said, "I'd had this conversation last night with our patient, and he had said that he didn't want to keep going with all these treatments and was ready to stop. Do you think it would be helpful for you and me, him, his wife, to maybe get together today and look at what's next? So we did. For that patient, it meant no more attempts to cure his disease, that we could focus just on his comfort and his quality of life, making sure that he was able to enjoy the time that he and his family had left. He could sit and, watch the Super Bowl, eat barbecue there in the intensive care unit on what ended up being the second to last day of his life. But it was a wonderful day, and I think was just the day that he was hoping for. And I think that's our opportunity that we have as nurses to bring out, what is it that you're really hoping for? What Atul Gawande calls the best possible day. What is the best possible day here for our patients? We can bring that opportunity to our physicians too, who may be feeling stumped when the tools that are traditionally at their disposal, as far as more infusions, more radiations, more surgeries, when that can't make a best possible day, what is there? We have so many beautiful opportunities as nurses to find out what that is for each individual patient and family. And we can give our physician colleagues the benefit of our understanding.
Kathleen, that was such a beautiful example. Showed the way that, again, like we've mentioned, patients are vulnerable with us as nurses. It showed how you advocated for that patient. And really, when they're trying to be strong for their family, because they might not know what the other side is going to look like for their family members, but they know how you would feel sad and they will feel sad, so they want to continue to be strong. They want to continue to do that next treatment. But is it really what they want to do, or are they doing it for that family member or their care team? To be able to give a patient the ability to really say that, and then you start that conversation for them as the nurse, and kind of take some of that difficult starting the conversation part out for the patient. And they can really then kind of tell their family members what it is that they want and how they want that to continue on and what their hopes and goals are for it. It's so powerful to think about that we as nurses have the ability to help patients in that way.
Absolutely. It's always surprising when we stop and take those moments to be vulnerable together with our patients, what we might learn. I think of a patient that I had cared for who had been the matriarch of her family for many years, and now her children were in the position of having to make difficult decisions for her. You can imagine a family that's getting ready to lose a parent. So sad, so hard, very distressing for the clinical team as far as watching her suffer and deteriorate day by day. And nothing that we were doing seemed to help, only to hurt. What came up through continuing discussions with this family was that this mom, that she would be okay with suffering to give her children time to be ready for her not to be there anymore for them, that this was a gift that she could give a few more last days so that after she was gone, they would be better able to move on with their life. And this seemed completely in line with who she had been through all of her life. And that was a goal that the clinical team could easily support, and really refocused our care on making that extra time that she had committed to struggling along less burdensome for her. that we could really hone in on symptom management and spend less of our time sort of spinning our wheels, trying to get code status change, trying to get a hospice consult. Instead, let's try to support this mom in her final push to be a good mom for her kids. And that enabled us to move forward as doctors and nurses without that feeling of futility and moral distress, but like we were joining this patient in a really heroic effort to do what was most important.
Thank you. Another excellent example. So, Kathleen, I've loved the examples that you've given, and you've just shown so many points and places where nurses can be part of these types of situations. But medical futility can be mentally draining for providers. You mentioned that earlier, with our physician colleagues and them wanting to keep trying to find answers. But what are some steps that nurses can take to make sure that they're prepared to deliver care in these situations?
That's the meat and potatoes of how we can keep being healthy as nurses and keep wading into these difficult moments. For me as an ICU nurse during COVID, to keep coming into work day after day, that's been a real challenge. And something that I've gotten to practice a lot is using the time when I'm going home. Earlier in the pandemic, when I lived walking distance from the hospital, I could walk home to my apartment. Now I live a little bit farther away and drive, but use that time to really notice I'm leaving. I'm walking toward home, toward safety, toward comfort, toward my couch and something good to eat, toward my nice comfy bed, toward my dog, just letting go, taking a breath, noticing where we are. We're not at work anymore. Can rest. There's something good waiting for us when we get home, and to be able to really soak up the rest that is waiting for us. It's something that I've come back to over and over. And even in the middle of a busy shift at work, I notice those moments of rest. Just soak them in. And that really also helped in de-escalating some of the clenching that we feel during a really difficult day. Just notice the moments for rest, soak them up, notice your body feeling more at ease, and then move into the next moment.
Thank you, Kathleen. I have so enjoyed our conversation today. It's a difficult one, but you've given so many wonderful examples and great tools for our listeners. And just to, again, encourage nurses and other care team providers who may happen to listen to our podcast, just to take that time to step back, reflect, soak it in. I love that. Those are such important things. We are coming to the end of our time. I think I could sit and talk with you for at least another hour or more about this, and just take that time to consider all the things. I have some questions that I end every one of our podcasts with that I would like to ask you, and we're going to do those in a real quick fire manner as we finish up. The first one is, what are some common misconceptions about medical futility?
Common misconceptions is that there is a cut and dried way to identify when a situation is futile. Just as we've been talking about today, we've got to stop, dig a little deeper. Then we almost always can find a goal that we can reach. Situations are almost always not futile. We just haven't seen the way through yet.
Perfect. Next question. What is something about this topic that's not often discussed, but you wish people knew more about?
I would say I wish that clinicians knew more about the concerns that patients and their families have around futility and moral distress, that they feel the same duties to each other that we feel for them, and are even more sensitive to feelings of having failed in their duties than we are. Let's not make them feel even worse. Let's recognize that we are all in this leaky boat together and use that as a point of strength and bonding.
So good. I like the leaky boat analogy. What additional training or resources do oncology nurses need to understand and approach medical futility appropriately?
In really getting a more nuanced understanding of medical futility, and by that I mean moving beyond leaning on our gut reactions and instincts, which can be sort of contaminated by our own assumptions, biases, every bad situation that we've been through in our nursing career so far, or difficult situations that we've had as a patient or that we have seen our loved ones go through. Let's take time, invest time in learning more about what is futility. Let's invest some time in learning more about how to understand our patients' goals, their families' goals, what their values are. So, taking some time to invest in communication training, ethics, if clinical ethics is something that's of particular interest to you, that's a great way to start. But also just really investing in learning how to communicate. And by that, I mean not sort of data dumping on our patients about their lab values or their scans or how they're responding to treatment, but asking questions. So pulling information rather than giving it. And then also learning how we can pause and attune to and manage our own feelings. And so that might be doing some mindfulness-based stress reduction training. Could be if we tend to sort of check out with our bodies, maybe doing some yoga to be more in tune with our bodies. So that way we can notice more quickly when we are becoming physically and emotionally overwhelmed in a situation. And then looking for continuing education opportunities like this one, like LNEC training, the End of Life Nursing Education Consortium training, things that may be available through your organization that give you a chance to sort of step out of an actual patient situation and reflect and practice with colleagues how to navigate these tricky situations.
Thank you. And my last question, what are some additional resources, whether that might be for patients and families or providers who might want to learn more about this topic?
There are a lot of good journal articles out there. I really do love the work of Dr. Atul Gawande. A lot of his presentations are available on YouTube, and so you can see them. He's the author of Being Mortal, Complications. He's a oncology surgeon from Boston, and so someone who also has worked a lot with end of life situations. The work of Dr. Tony Bach, who's a medical oncologist from Washington State. He's also been involved in an organization called Vital Talk, which is the main organization training physicians on how to have difficult conversations with patients and families. People can go to vitaltalk.org, and there are all kinds of communication tools and roadmaps, and then little tiny video blog posts about things like responding to strong emotion or what to do when it seems like there's nothing else that we can do. There's a program called Impact ICU that I've been involved in for now 10 years that has some video training specifically for nurses available on the Vital Talk website. And so people can go there and learn a lot more about how to talk with patients and families.
Thank you. And again, Kathleen, thank you so much for being with me today. I think that this podcast is going to be very valuable for our listeners and one that will be shared often. It's definitely an area that oncology nurses deal with pretty regularly. So I appreciate you taking the time and being with us today, and just, again, your examples and your expertise. Do you have any final comments for us?
Thank you, Stephanie. I think oncology nurses, critical care nurses, that we are brothers and sisters at heart, that we come from traditions that value rescue, and in fact, even talk about failure to rescue as a preventable harm in hospital metrics. Please don't look at patients dying or patients suffering as your personal failure. You are doing your best under really, really hard circumstances right now. Keep doing it. Keep taking care of yourself. Just know that you are very special. We all appreciate each other. Go out and thank your coworker, and then do something nice for yourself.
Thank you. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.